If you're watching this film, you've probably already been told that you may have a sarcoma. Today, we're talking about how pathology helps with a precise diagnosis and classification. Many people might think it's an easy task, that you just look at it and immediately know which sarcoma it is. Unfortunately, it's not that simple. The main problem is that there are well over 100 different types of sarcomas, and it's very difficult to figure out exactly which one it is. Dear Professor Wartelman, you are the director of the Institute of Pathology here in Münster, and we would like to talk to you about this very exciting topic today. I would like to begin with a question. What role does pathology play in the diagnosis or classification of sarcomas?
Well, of course, every medical specialty tends to see itself as the most important. But when it comes to pathology, that's actually true, especially with sarcomas. We're dealing with rare tumors, and diagnosing them often requires a wide range of methods. Ideally, you've seen many of these tumors before, so you can recognize them again. The kind of therapy used, something we will discuss later, depends greatly on the final diagnosis, and making that diagnosis requires a certain level of expertise.
Exactly, because that is the key point. The diagnosis or classification of the sarcoma determines the treatment and how successful it will be.
Yes, exactly.
You mentioned that sarcoma is indeed rare, and that it's important to see it more often to recognize it. How often do you actually encounter sarcomas in your daily work? Let's say, per month.
Well, actually, it often comes in waves, simply because the submissions that we receive from external sources vary in frequency. That means we are not really able to plan for them. Over the course of a year, we see around 2,000 sarcomas, or soft tissue and bone tumors when you add everything together. Many of these are sent to us from outside institutions, but of course we also have our own patients here at the clinic.
And if you think about a regular pathologist working in a typical clinic, how often do you think that person would encounter a sarcoma?
Much less frequently. Maybe once a week at most, or even just once a month. Sometimes only once every 6 months. That depends on the type of clinic. In private practices, where freelance pathologists work, such tumors might appear only every 6 months, since they mostly examine biopsies from the gastrointestinal tract or other regions where these tumors are rare.
Okay, so that clearly shows how much more often you see these tumors compared to everyday pathology practice.
Yes, exactly.
That is why it is so important to go to a center that specializes in sarcomas.
Exactly. If you look at how many sarcoma centers exist, 21 are officially certified, but there are definitely more that treat sarcomas. Not just probably, definitely. But even though there are 21 certified sarcoma centers, that does not necessarily mean that every medical discipline within them includes true specialists in this field. That is why it is so valuable that we work together and support one another.
Before any treatment can begin, a sample has to be taken from the patient, a biopsy. We have already made some films about that, so feel free to watch those. How does the sample get to you, and what do you do with it?
Exactly. There are 2 ways this can happen. Sometimes the tissue is sent to us fresh, for example during surgery or right afterward, when a quick section is needed and results are needed immediately. Sometimes we freeze samples for research or further testing. But the much more common situation is that they arrive in formalin, a liquid that fixes the tissue and makes it stable for analysis over time. This method is actually more convenient because most of the tests we perform are done on formalin-fixed samples, but we can handle both. Once the sample arrives, it is processed. The water has to be removed. These days, machines do all of that. In the end, you get a paraffin block that can be sliced for examination.
What would you say is the downside of using formalin?
The problem is that formalin is toxic, which of course is not ideal. It can be a health risk for staff who work with it every day. Also, if the tissue remains in formalin for too long, some testing methods may stop working. You might not be able to extract DNA or RNA properly anymore, and immunohistochemistry may also become unreliable. That is why it helps when we know how long the sample was stored in formalin. That way, we can process it in the right order.
What kind of additional information do you need about the patient the sample came from? Do you need to know a lot of patient details too?
Yes, many clinicians think we do not need that information, but we do. Name and date of birth already tell us the age. Gender can be more difficult to determine, especially if the name is ambiguous. So it really helps if we know that too, because some tumors are more common in women, others in men. The more background we have, the better our conclusions. For example, it is very important to know if the patient had another tumor 5 years ago, and if so, where it was and what kind it was. What prior knowledge do we have? Is there already a metastasis somewhere, like a secondary growth in another organ? All these questions are important to us because if we know there's already a metastasis, then we can infer much more about the biology at least, or we can say this could be the primary tumor. Or no, it's not possible because it would not metastasize. So, everything we learn is beneficial to us.
Is it also important for you to know how the biopsy was taken? Do you sometimes receive any images, like PET-CT scans, where you can actually see the tumor and understand how the biopsy was done?
That would be ideal. That would really be the best case scenario. And with sarcomas, this often falls under what we call consultation pathology.
What does that mean exactly?
Consultation pathology means giving a second opinion for a hospital or institute located elsewhere. In those cases, we often lack access to the patient's medical history. But here at our clinic, I can log in with the patient's name and date of birth to view scans, lab results, or doctor's notes. We do that frequently. But when we get something from an outside source, from a place that is not Münster, then we often know nothing. We may not even know the size of the tumor or exactly where it is located. And that is clearly a disadvantage. When giving second opinions, we often have less background information than we do with our own cases here in the clinic.
Okay, so you are hoping for a digital world where all information comes together. That would be great.
In that case, you could look up the information that really matters. It does not help if I receive 50 pages of medical documents for every case. A clear and concise summary would be far more useful. I could definitely work with that if it were part of a digital patient file.
Let us hope we can achieve that soon. Yes, that would really be a big step forward. Now, once the sample arrives, and since pathology has different steps, how do you actually begin?
Right, so when the sample arrives, the first thing we do is check its size and weight. Pathology is often called the field of measurement and numbers, and that is very true. It makes a difference whether we are looking at a large tumor or a small, thin biopsy. We document that first. In the cutting area, the sample is placed, weighed, and measured.
But then, what you actually received was that little worm.
And if what we receive is just a little worm, then of course we measure the worm as well. I need to know how long it is and how thin or thick. That helps me later on when I look at it under the microscope, so I can tell whether I am actually seeing the complete piece of tissue or whether it might not have been cut properly. We document things this way to ensure that everyone involved later knows the material was properly handled and embedded.
Now I really understood what you meant. So sometimes you actually receive the entire tumor after surgery?
Yes.
Sometimes we receive the entire tumor after surgery. You were referring to the beginning of the process after diagnosis. And yes, when we get the whole specimen, we can examine it closely, measure and weigh it, and better understand its characteristics.
Exactly. In such cases, we also take photos of the specimen and slice it to see what the tumor looks like inside, whether it shows different structures or patterns in certain areas. The biopsy is really only the first step. And there are even cases where we do not receive a biopsy at all before surgery, even though that should be the standard procedure. But sometimes patients just show up. They thought it was only a bruise, and then it turns out to be a tumor. In those cases, we get the entire tumor straight away.
Okay, exactly. Now, going back to the scenario where you received just a biopsy sample, what exactly do you do with it? Because the main goal at that point is to find out what type of tumor it is.
Exactly. In that case, we follow a standard procedure. Every sample undergoes a basic staining method called hematoxylin and eosin staining, or H&E for short. The tissue is processed overnight. By the next morning, the biopsy, the little worm as we call it, has been dehydrated, infiltrated with paraffin, and embedded in a block. From that block, we can cut thin sections.
And this staining process means that something is applied to the sample, which reacts with the cells and causes them to take on color.
Exactly, they take on color.
So do these colors indicate whether the cells belong to one specific type or another? Is that how it works?
Yes, that might be a bit too simplified, because ultimately we can only say that the cell nuclei generally turn blue-violet, and the cell body turns pink. Those are the two predominant colors. And then, of course, we also have to look at how large the nuclei are and how wide the cytoplasm is. Is the cell shaped? How does it arrange itself? How does it grow? Does it form fascicles or some kind of whorl? Or is everything growing in a completely chaotic way? Because these aspects are also evaluated, and you observe this in the classic H&E staining, and based on that, you decide what additional methods might be necessary to move forward. In some cases, H&E alone is sufficient.
What was H&E again?
That refers to hematoxylin eosin staining, where the nuclei are always stained blue and the rest of the cell appears pink. And based on the staining, which is our standard, it is then decided, do I now perform immunohistochemistry? That is, do I conduct special examinations to determine whether it is a smooth muscle cell or a neuron-derived cell, or what is the cell composition in general?
First, you have the staining. Now I have learned that the staining itself does not differentiate between the cells, but you look at them and try to identify the type of cell based on your observation.
We suspected, I would say.
Okay, exactly. And what exactly does immunohistology do? How does it actually work?
That provides more detailed insights into the tumor, for example, which surface proteins are present on the cells, and which internal structures or components within the cell are involved in the tumor's behavior. Both the cytoplasm and the nuclei can be stained, allowing us to determine whether it is a muscle cell, a nerve-derived cell, or an epithelial cell, in other words, a glandular cell. These cell types can be distinguished quite well, because each one has specific protein molecules that are not present in the others. So there is a pattern you observe, and often it is not just one immunohistochemical test, but 10 or even 20, sometimes quite a few.
So it is called immunohistology, but are there actually different methods involved?
Yes, you have to imagine that we use antibodies for this. These antibodies are specifically developed to recognize certain structures in the tissue, and they bind to a particular protein molecule.
Do they react with each other?
Yes, they react with one another, and at the end, a dye is attached which marks the cells that carry the relevant protein. We have about 150 to 200 antibodies that we can use routinely. Of course, we do not use all of them every time. That would not be practical. Instead, there are specific lists that we typically work from. For example, if we suspect a leiomyosarcoma, we use different stainings than we would for a liposarcoma.
So you already looked at the sample under the microscope and based on your knowledge said something like, yes, that looks like this. Then you carry out the specific tests. Exactly.
And ideally, that initial assumption is confirmed, but in the worst case, it is not. Then I have to move to the next stage. I have to think, if it is not what I suspected, what else could it be? I might need to test other possibilities, or take the next step, which would be molecular pathology.
So what do we actually do in molecular pathology?
That is primarily linked to the tissue section, meaning it is carried out directly in the tissue. Unless, well, there is one exception I should mention. There is a method called fluorescence in situ hybridization. It is a terrible term, which is why we always just say FISH because it is easier. That means you want to attach a fluorescent dye to a specific gene. For example, in Ewing's sarcoma, the EWSR1 gene plays a major role. You want to visualize that and see if it is intact. So you use these fluorescent dyes, and in situ means you perform it directly on the tissue section. If you simplify it, the probe is essentially hybridized, or cooked together, with the tissue. Ideally, it binds only to that specific gene, and later, when I examine it under a fluorescence microscope, which is required for this, I can actually see the probe and determine whether the gene is intact or not. And that is very helpful because it is fast, similar to immunohistochemistry. You do not have to wait for weeks to get a result, but usually by the next day you already know whether something is wrong with the gene, and you can follow that path. That would be the simplest kind of FISH test,
and its purpose is to help guide therapy. But first and foremost, the goal is to determine whether the tumor is even the one we suspect.
Exactly. Diagnosis comes first. That is always the first step. Some immunohistochemical antibodies also directly highlight a therapeutic target. Ideally, you can identify that structure in the tissue and confirm that the tumor expresses it. A typical example would be a gastrointestinal stromal tumor and the KIT receptor. In this case, there is a medication specifically targeting the KIT receptor, and I can also see the KIT receptor stained in the tumor. That allows me to be confident that the therapy could actually work. This is exactly the idea behind many of the new therapeutic approaches, to directly target the therapeutic goal by staining it as a biomarker. That way, the treating physician can say, "This target is present on the tumor, so I can address it directly with the appropriate medication."
And for this type of molecular pathology, do they need fresh samples?
No, that usually works just fine. In fact, all of this can be done with paraffin-embedded material, which is our standard. All our methods are tailored to work with that. The only exception would be if I want to analyze the entire genome of a tumor cell, then it is better to use fresh tissue. This will become more common in the future, but then you always have to ask yourself, what am I actually going to do with all that information? The entire genome is a lot of data, so you really need to consider whether such extensive testing even makes sense. But that is a separate issue. That's a topic for another day.
Yes, exactly. You already hinted at it a little. Are these 3 steps, histology, immunohistology, and molecular pathology, always performed or only sometimes?
Not necessarily every time. That always depends a bit on the judgment of the pathologist, whether they feel all 3 steps are needed or not. In other words, there are tumors where, if you have seen them often enough, you might no longer need immunohistochemistry because the diagnosis is clear. But on the other hand, especially with tumor diseases, we often want to understand them more precisely. And that is when molecular diagnostics becomes important, to define the tumor more accurately and predict the best therapy.
Is that also used later on for research purposes?
That depends. It is actually a very interesting question because now, at least at all university hospitals, patients are routinely asked to give their consent. Of course, this is for highly important purposes and always in a pseudonymized and anonymized form. And of course, we did not have that consent many years ago, so historical samples, let us say from 10 years ago or older, are still stored in our basement. But there is no consent for them.
Oh, I see.
Yes, these tissue blocks can be stored for a very long time, nearly indefinitely.
They don't break down or anything.
No, and that's the advantage. Pathology preserves the tissue in a way that keeps it usable for a long time. Otherwise, it would not last.
Then we can also throw it away.
Yes, and that is why there is debate. Some people argue that because the pathologist processes the tissue and preserves it, it should belong to pathology. But that is a topic in itself. Who actually owns the tissue? In our view, it belongs to the patient, and they should clearly have access to it. And that is why we have clear rules. For example, the sections must be kept for at least 10 years. There is also a recommendation to keep the entire blocks for that long, because we might still need them. If we discover a new biomarker tomorrow, we can go back to those blocks from 10 years ago and test for it.
So that means it is really important that patients give their consent? Do we want to advertise here again?
Yes, we should definitely encourage that. But what is interesting is that most patients are happy to give their consent because they understand why it matters. It is often healthier individuals who are more hesitant saying, "I'm not sure if I would want that." And that shows how much it depends on who you ask. The topic of data protection is very important. Everything must be pseudonymized, anonymized, and securely handled. But it also creates limitations. Some studies cannot even be conducted because consent from the past cannot be retrieved.
Ah, retroactively, of course.
Exactly. I cannot simply call someone and say, "You had a tumor 6 years ago, and now we would like to do something with it." From my perspective, that would be completely unethical, because maybe the person does not want to be reminded of having had that illness. So it is not that simple. And if someone from pathology gets in touch, it might be unsettling, because most people do not know what we do here and think, that must be a bad sign.
In what sense? Why?
Well, many people tend to associate pathology more with autopsies or the deceased, rather than with research or studies that support therapy. That is why obtaining retrospective consent is often difficult, and it is usually not very reassuring for patients either. It is completely different when a clinical colleague calls. I have discussed this with some of them already. Patients are happy when their doctor gets in touch and asks how they are doing. They see it as appreciation and feel taken seriously. They usually give consent without hesitation. The challenge is rather, is it even legally permissible?
Now, you just mentioned that some of these tests can go very quickly, but many patients feel that it often takes quite a long time until their sarcoma is fully typed. So, what is considered typical in that regard? Or, put differently, when does it actually take a long time, and why?
Exactly. We already mentioned that there is a multi-step process involved in how we handle these cases. In general, cases do not come to us directly. They are first handled by a local pathologist. So, the diagnostics take place in several steps. An H&E stain is performed, immunohistochemical tests are done, the case is reviewed again, and then discussed in a tumor board. That alone takes 1 or 2 weeks if everything goes smoothly. Then there might be the realization, something about this is odd. We would really like a second opinion. So the material is sent by regular mail. Yes, just like an ordinary package. Eventually it arrives here. We record the case again. We go through the exact same process. First, we prepare a hematoxylin and eosin stain, possibly followed by immunohistochemistry and molecular pathology. Especially the latter, molecular pathology, can take 2 or 3 weeks before results are available. And then, of course, someone has to sit down at the microscope, review everything, and compile the final report. That someone could be me, for example, and if you take a look at my desk, you will see thick stacks of cases. They are waiting to be finalized, and that takes time. And I somehow have to manage that in terms of time. When the stacks grow larger, that alone can cause additional delays.
But now I just want to briefly interject in molecular pathology. It's not that it's just lying around waiting for someone, but rather the processes themselves take a long time. These are chemical processes that take place. They just take time.
Exactly. You have to imagine we are talking about methods like FISH, fluorescence in situ hybridization, which we already discussed earlier. So you have to imagine we are talking here about methods like FISH, which stands for fluorescence in situ hybridization. We've already discussed that technique earlier.
Okay, I see.
And then the process goes like this. We have this tissue block which contains paraffin, and the paraffin has to be removed first. Next, thin slices are cut, and there are several steps needed to remove the paraffin from the tissue, because it would interfere with any further analysis. After that, the DNA has to be extracted from the tissue, again using a multi-step procedure. This means the nuclei must be broken open, the DNA extracted and purified. And in the end, there is often not much DNA available, so it might be necessary to amplify it before using it for further testing. This process is called amplification. You use various techniques to multiply the small amount of DNA, ideally in the exact location that is relevant for the question at hand. Once that is done, the DNA must be sequenced. That is carried out by machines, but even then, it often takes several hours for all the sequencing cycles to finish, resulting in a huge amount of data.
Okay.
This pile of information is raw bioinformatic data that first needs to be processed by algorithms and software before it becomes readable. Then someone has to evaluate it from a bioinformatics perspective. And the length of this explanation alone shows how time-consuming it is.
That clarification was important. These are not just samples in line, but complex processes that take time.
Exactly. The more we investigate, the more we discover in a single tumor, and that means we also need to evaluate whether each piece of information is actually relevant in the given clinical context. We are now conducting more and more analyses not only at the DNA level, but also at the RNA level. Anyone who remembers their biology classes might recall that there are several steps between a DNA strand and the final formation of a protein. And RNA is where we are now doing a lot of searching. We often find molecular changes that are likely to be significant, but that we have never seen before. So these are entirely new findings. And naturally, that means we first have to search the literature and the internet to find out whether anything like this has already been described, and if so, in what context and what it might mean now. So it does have a slightly scientific touch to it, of course.
Let us return to this question. If we want to type a sarcoma, what are the specific challenges? At what point does it become particularly difficult?
The hardest cases are those that appear harmless but are not. You don't always look into the microscope and immediately think, this is a dangerous tumor. Sometimes you do, yes, but other times it just looks like a scar. Or it might be a residual effect after a previous inflammation, where you would not initially suspect a tumor. These are the particularly challenging cases because they can be overlooked at first, not considered malignant, and simply removed. Later, they might reappear locally. The patient might come back 10 years later with a lump in a different area, and only then you realize, oh, there was something there 10 years ago. Should we compare that? It is uncomfortable when there are cases that hide themselves like that, simply because they do not immediately catch your eye.
At the beginning of the film, we mentioned how many different types of sarcomas there are. I imagine that must make it very difficult to distinguish and classify them. You mentioned over 100, and I have even heard numbers like 150. How do you manage that? What are the main challenges?
One might assume that with enough experience, you could just look into the microscope and immediately know the diagnosis. But it does not work like that. Even I sometimes look into the microscope and think, oh no, what is this? Then I have to ask myself what approach or method I should use to find out. In some cases, you cannot clearly identify the type, and then we call it undifferentiated. That means the tumor cannot be assigned to a specific direction or type, so it is classified as an undifferentiated sarcoma. That can be a bit unsatisfying because you have already tried many methods to find out whether it is a specific subtype. But it is also a valid result if, in the end, the tumor remains undifferentiated.
Just to clarify, undifferentiated does not mean they are all the same. Even among undifferentiated sarcomas, there are significant differences.
The issue is that they often have extremely complex karyotypes. One cell might have 46 chromosomes, another 96. There is a lot of genetic variation within a single tumor. This diversity means that undifferentiated sarcomas are not uniform either. They differ significantly from one another. This happens because as the tumor continues to grow, the cell divisions become increasingly chaotic. The genetic order breaks down. The more disorderly it gets, the more aggressive the tumor becomes. These are some of the most aggressive types we know. Of course, we try to categorize such tumors, hoping this will help us find a more targeted therapeutic approach. That is why undifferentiated sarcoma is often a diagnosis of exclusion. In the end, if nothing else fits, that is the label we give it. And in between, there are many diagnostic steps. So why is this so difficult? Well, there are tumors that are very clearly defined. These usually have consistent molecular alterations, and we can assign them to a specific category with confidence. But there are others where we can only hope that they fall into a certain category, because the diagnostic criteria sometimes overlap across tumor types, and the boundaries are not always as clear as we would like. These are the ones that demand extra attention. Researchers all over the world are trying to define new criteria, but it is a slow and meticulous process.
And that really sets sarcomas apart from cancers like those of the colon or breast. Those might come in a few different types too, but not nearly to the same extent.
Exactly. What is unique about mesenchymal tumors, as we call them, is that they originate from connective tissue or connective tissue-like cells. Unlike carcinomas, they do not form glands, so they do not mimic normal tissue as closely. And we do not know any precursor stages in sarcomas. If you think of colon cancer, most people are familiar with the idea of a polyp developing into a carcinoma. Under the microscope, it already looks dangerous, even if it has not yet invaded deeply enough to be classified as cancer. But sarcomas do not have such defined early forms, or at least they are not well understood. That makes it harder to detect them early. They often show little resemblance to the nearest normal tissue type, so we rely heavily on immunohistochemistry and other tools to determine what we are dealing with.
Are there also cases where a biopsy has to be repeated?
Yes, indeed. Just think again of the example I mentioned earlier with a very large tumor. Imagine taking a biopsy punch that is 1 centimeter long and only 1 millimeter thick. You always have to ask yourself, is that truly representative? Can such a small sample reflect the whole tumor? Sometimes it can, but sometimes it cannot. A large tumor may have poor internal blood supply, leading to areas of necrosis where cells have died. If the biopsy is taken from such a necrotic area, there is no chance of making a proper diagnosis. Tumors can also be heterogeneous, meaning that some parts contain many cells, while others contain very few. This variation presents another challenge in sampling. This is why, when it comes to grading later on, we might not always be able to make an accurate assessment. The sample is simply too small, and we have not seen the entire tumor.
Okay, I understand. So finally, the question. What role does pathology play in deciding on therapy?
There is a simple truth. Without the correct diagnosis, there can be no appropriate therapy. That is exactly how it is. If you are uncertain and say it might be a liposarcoma, or perhaps a malignant peripheral nerve sheath tumor, or something else entirely, then it becomes much harder to choose the right treatment. The level of aggressiveness of the therapy depends on how aggressive the tumor is, and that, in turn, depends on making the correct diagnosis. In that sense, it may sound like a cliché, but if the diagnosis is wrong from the start, the entire treatment path could go in the wrong direction.
You have already mentioned several key points. Next, we want to talk with you about grading and staging. Once we cover that, we will have completed the diagnostic part, and it should be clear how therapy can proceed. Professor Wardelman, thank you very much for your fascinating insights into pathology. We will continue shortly.